And the last session is on HFPEF New Insights. May I please request Dr. V.K.
Thank
Chopra
you, Dr.
and
Kaur.
Dr. Javed Butler, Dr.
Thank you.
John McMurray to join the session as a respected moderator and panelists. And the first speaker for this session would be Dr. Javed Butler from USA, and the second speaker would be Dr. J. McMurray from UK. I would be introducing our honorable moderator for the session, Dr. V.K. Chopra. Dr. V.K. Chopra is a Senior Director, Clinical Cardiology, Heart Failure and Research at Mac Super Speciality Hospital, Saket, New Delhi. He is the founding president, Heart Failure Association of India. Dr. Chopra has authored more than 90 original papers and has also reviewed and served editorial responsibilities for many of an esteemed journals. So, Dr. V.K. Chopra, over to you, and we will begin with the session for today. And with that, let me remind all of you that we are going to meet again tomorrow. Tomorrow will be the second day of our conference. See you all on time. Till then, stay well, take care. And again, handing it over to Dr. V.K. Chopra. Thank you.
Thank you so much for a very kind introduction. Welcome to the last session of the first day's program. As we know, the management of heart failure with preserved ejection fraction has posed many challenges in the past. For unlike heart failure with reduced ejection fraction, we had very few effective therapies except management of comorbidities and diuretic. All that has changed in recent past, and new treatment modalities have become available. So for many of us, it is still a relatively new field. To enlighten in this area, we are privileged to have with us two exceptional researchers and teachers who have led so many heart failure trials over several years and educated us in the nuances of heart failure management. Their achievements are too numerous to be listed. To save time, with your permission, I'll skip your detailed introductions. So first, Dr. John McMurray, who we all know and we all love a lot. He is currently a professor of medicine and honorary consultant cardiologist at Queen Elizabeth University Hospital in Glasgow, and he has led a large number of trials. We all know him very well. He is going to discuss the role of ARNI and SGLT2 inhibitors in heart failure with mildly reduced ejection fraction and heart failure with preserved ejection fraction with the new analysis of the data that has become available. And the second speaker is, again, somebody very dear to us, Dr. Javed Butler, good friend of ours, President, Baylor Scott and White Research Institute in Dallas, Texas, and a distinguished professor of medicine in Jackson, Mississippi. We recently had this STEP-HF trial, which is hot off the press, and this explores the role of semaglutide in obese non-diabetic patients at heart failure with preserved ejection. So a very warm welcome to both of you, John and Javed. And let me first invite Javed to give your talk. We'll have both the talks together and have a discussion at the end. Over to you, Javed.
Well, thank you very much. Can you see the slides?
Yes.
Yep. Perfect. So very much appreciate the opportunity to present in this forum and to talk to everyone. And Vijay, John, great to see you. So STEP-HFpEF was a trial that was recently presented, recently published, and there are a couple of secondary papers that have already been published, and some of the other analyses will be coming out pretty soon as well. So I'll try to briefly summarize what we know at this point. So by way of background, we know that patients with heart failure and preserved ejection fraction accounts for almost half the patients with heart failure. And the recent data suggests that that proportion is actually increasing. So the overall proportion of patients with HFpEF in the near future may well be more than heart failure with reduced ejection fraction. Now, most patients with heart failure with preserved ejection fraction are either overweight or obese, and that is in excess of 80%. Now, those patients who are obese or overweight with heart failure with preserved ejection fraction tends to have certain specific features in terms of their hemodynamics and in terms of their clinical features, that there is a lot of interest in this so-called obesity HFpEF phenotype, including cardiac structure and function, including epicardial fat, including the correlation between the right and the left ventricle and the mechanisms of intraventricular septum, and then obviously systemic effects of adiposity as well, including inflammation and oxidative stress. We now do have a therapy, SGLT2 inhibitors that have been approved for patients with HFpEF, and at least for a good segment population of HFpEF, the data are positive at ARNI, and we'll hear more about that by Dr. McMurray soon as well. But there's no sort of targeted therapy focusing on this obesity phenotype of HFpEF, which was the reason this trial was performed. Now, we know that semaglutide, once weekly GLP-1 receptor agonist, has been approved for both weight loss and for diabetes management as well. So there were two sister trials that started, STEP-HFpEF and STEP-HFpEF-DM. One trial specifically had patients only with diabetes, and the other trial specifically had patients excluding diabetes, to see the effect of semaglutide 2.5 milligram titrated dose on physical limitation, exercise capacity, and some other endpoints in obesity HFpEF phenotype. Why would semaglutide work? So obviously the simplest answer is, well, if you lose weight, then you might feel better with your heart failure, and that it has sort of nothing to do with heart failure. And in the Q&A, maybe we can have a discussion around that. But there are other factors that are related to adiposity as well, and the mechanism of action of the drug, that one can postulate direct benefit for HFpEF as well, including reduction in visceral fat, plasma volume, inflammation, intracardiac pressures, energetics. So it's a little bit of a complex, interdigitated field, but there are substantial reasons to believe that it might be beneficial from a hypothesis perspective. So the trial enrolled patients with BMI greater than 30, greater than or equal to 30, who were randomized to semaglutide or placebo, up titrated to the maximum dose of 2.4 milligrams per week. The key inclusion criteria was EF greater than 45%, baseline KCCQ less than 90, so at least some mild degree of lower KCCQ values, and 6-minute walk test of greater than 100, so at least ability to do some walking. And then some evidence of either hospitalizations or elevated filling pressures. Those patients with diabetes or raised hemoglobin A1C were excluded. Self-reported weight change, substantial 5 kilogram, was excluded, and any planned bariatric surgery was excluded as well. Now, this is a complex slide, the way the statistical plan was designed. But I won't go into the details of how alpha sharing worked in this slide, because at the end of the day, it really didn't matter, because all of these endpoints were positive, as I will show you. So this complicated schema of sharing alpha was at the end proven to not be necessary. But suffice it to say that the primary endpoint was a co-primary endpoint, looking at improvement in Kansas City cardiomyopathy clinical summary score. So for those of our friends who are not familiar with the KCCQ score, it's a 23-item questionnaire. So you ask 23 questions, and the 23 questions are subdivided into sort of in 3 domains. So one domain is just related to symptoms, symptoms frequency, symptom burden. So that is called TSS, total symptom score. If along with symptoms, or TSS, if you add physical limitation, how much can you walk, what can you do, that is called CSS, or clinical summary score, and that was the primary endpoint of this study. But then there are other domains of, social integration, sexual function, how do you integrate, what do you perceive your quality of life to be? Those kind of things combined is called OSS, or overall summary score. So we included physical limitation and symptoms in the CSS as the primary endpoint. Body weight loss, ability to walk, so 6-minute walk distance improvement. And then we created a hierarchical composite win ratio, looking at the risk of dying, risk of hospitalization, and then a 15-point, 10-point, and 5-point improvement in KCCQ. So again, a lot of the previous data would suggest that 5-point improvement in KCCQ is clinically meaningful, 10-point is really impressive, and 15-point as well. And then finally, in order to get some idea about mechanistic effects of the drug, we looked at the anti-inflammatory effect and CRP values as well. So baseline patient population, really nothing spectacular, something that you would expect in HFpEF. It's a female. Overall, we went to an EF greater than 45%. I'm sure that the female proportion would have been even higher if we went to greater than 50%. Age around 70 years. This is the BMI category. So we had the average BMI was 37. So this was a pretty obese group. And then if you look at the data for 30 to 35 versus greater than 35, there was a 1/3, 2/3 split. So about a third of the patient were EF 30 to 35, and 2/3 of the patients were greater than 35. LVEF around 57. Baseline KCCQ was 59. So these patients were pretty symptomatic. And baseline 6-minute walk test was about 320. Overall, really no significant difference between the semaglutide or the placebo group. Very well treated for comorbidity. So like most HFpEF trials, we have seen about 80% use of RAS inhibitors and beta blockers, and some diuretic use 80% as well. So what did the trial show? So the primary endpoint was a composite of KCCQ and changes in body weight. So again, just to put this in perspective, although we have to be very careful, we cannot just compare different trials. These are different interventions, different baseline clinical characteristics, different interventions, baseline medication, etc. But just to give you a general sense of what sort of benefit we have seen with, other medical therapies for heart failure, the average population difference. So there are two ways you can look at the KCCQ score. One is the average population difference. And then the second is something called responder analysis, like what are the chances that you will improve by 5 points or 10 points. So the average population difference in heart failure trials with medical therapy has been somewhere in the range of 2 to 3 points. Some small studies have shown up to 5 points, but 2 to 3 points improvement. But in device trials, many of them were actually without sham procedure, so it's a little bit tough to ascertain. It's somewhere in the range of 10%. And then it starts going into 15, 20% when you look at, TAVR or LVADs or things like that. So that is sort of the background landscape. But with medical therapy, we have found about, say, 2 to 3 point differences in population. So in this trial, the first thing which was a little bit surprising that, or maybe not, that's why we do placebo-controlled trial, that with regular follow-up and close monitoring, there was significant improvement in KCCQ in the placebo arm as well. But there was substantially higher improvements in the Kansas City Cardiomyopathy Questionnaire, and the average population difference was almost 8 points, highly significant, 7.8 point difference, controlling for the changes in the control arm. So again, I absolutely don't mean to compare drugs across classes and across trials, but if you look at what we have seen over the heart failure landscape, this result was pretty impressive, and we were pretty happy. Weight loss, so that was really not a surprise. I mean, these drugs have already been approved for weight loss, and we saw basically what we were expecting. So not much weight loss with the placebo, and significant weight loss with a therapy, and then the net percentage body weight loss was about 10.7%. So then we go to the other secondary endpoints. So we looked at 6-minute walk test over time. So the curve seemed to continue to increase at 52 weeks, whereas it was plateau. For the placebo arm, the net difference was about 20 meters between the two groups overall. That was also highly significantly different. And then this is the hierarchical endpoint that I was mentioning that we had created to look. And that composite endpoint was significantly in favor with treatment with semaglutide. Not many deaths, so it really did not contribute. Fewer events, heart failure events, but predominantly in favor of semaglutide. And then 15-point, 10-point, and 5-point improvement in 6-minute walk test all contributed to the win ratio of 1.72, again, highly in favor of semaglutide. Now, all of these data, you can say, well, that's great, But does any of this have anything to do with heart failure with preserved ejection fraction? If people are severely obese and they lose 10% of their body weight, maybe that's why they are walking more. Maybe that's why their symptoms are better and their KCCQ score is better. So I would say two things. One is that probably from our patient's perspective, it really doesn't matter whether you are making their heart failure better or making them better because of the weight loss. Remember that we are also living with a legacy of this weight loss in epidemiologic studies, the obesity paradox, that obese patients end up doing better. And we never really had an idea about intentional weight loss, although with bariatric surgery, we thought it was a good idea. And here we are proving that intentional weight loss really make people feel better. But now the question is, what is HFpEF versus what is just obesity? So we have some indirect ideas that we feel that the heart failure status got better as well. So the first thing is that the CRP got better. So if you look at the proportional changes in CRP, that was cut in half with the use of semaglutide, a highly significant result in favor of semaglutide as well. So your inflammatory burden went down. So this starts giving you a little bit of a mechanistic link because inflammation is really related to heart failure. But you can still challenge that and say, well, adiposity is associated with inflammation. So maybe still it is all related to just adiposity. But what is interesting to note is that obese patients have lower NT-proBNP. We know that for a very long time. But what is interesting is that if you look at studies of weight loss, when people lose weight, their BNP levels tend to go up because the obese patients have lower BNP production. So as the weight goes down, the BNP tends to actually go up a little bit. Whereas in this trial, we actually saw a reduction. So there was a substantial weight loss, and yet there was a reduction in NT-proBNP with the use of semaglutide, which I think is the most direct evidence that we have that the benefit was more than just weight loss and that there was a direct benefit to the biology of the disease. And again, I want to be careful not to oversell some of the results. I mean, there were only 13 heart failure events, hospitalization or outpatient IV diuretic. But boy, it's really tough to ignore this graph that 12 out of the 13 occurred in placebo and only one occurred in semaglutide. So again, I would not say that today we should treat our patients and tell them that they have any guarantee that their heart failure hospitalizations will go down. I think these are great data that would support or justify a large outcomes phase 3 trial. But again, if you look at the cumulative data, at least to my eyes, it looks very complementary and suggests that the heart failure status is getting better and it's not just the part of obesity. Now, we did some additional analyses looking at two things. One, baseline BMI, so 30 to 35, 35 to 40, and greater than 40. So in other words, if it was all related to weight loss, then maybe we should see two trends. One is that most of the benefit should be really people who are really obese. So that was baseline BMI. And then second, the percentage body weight loss. So 5%, 5 to 10, 10 to 15, 15 to 20, and greater than 20%. So again, you would say that the greater the body weight loss, the more improvement in endpoints. And if you have a little bit of weight loss, then maybe you would see no benefit. So let's see what those data shows like. So here is the data for baseline BMI and improvement in physical limitations. So again, no correlation, benefit seen across all three BMI groups. Weight loss, again, was seen in all three groups. And there was actually a trend. I mean, if you look at interaction p-value, that was negative. But if you look at the sort of the visual changes over 52-week, it was more in patients with higher baseline body weight. But here is sort of the biggest sort of kicker. So those patients with weight less than 5%, those people did not have as much benefit. But boy, I mean, that was still even within group statistically significant. Almost was on the right of the unity line. The difference was 5.4 points in KCCQ with a margin of minus 0.1 to 10.8. And then the other four groups are almost sort of interchangeable with substantial benefit. So regardless of the baseline body weight and regardless of the percentage change, the benefits were seen pretty consistent. So where do we go from here? Well, this was the data for STEP HFpEF without diabetes. There's a sister trial going on, STEP HFpEF diabetes. We do have some inkling that patients with semaglutide who do not have diabetes lose more weight than those who have diabetes. So it's going to be interesting to see how much weight loss is there and how does that correlate with all of these outcomes you're seeing in non-diabetes patients. And then there is another cousin of semaglutide called tirzepatide. It's a dual agonist. It is a GLP-1 receptor agonist and GIP as well. So this is a dual agonist that is being tested in a trial called Summit trial, and that trial is also ongoing. So we will have more idea about this patient population as well. So to summarize, in patients with HFpEF, obesity is very common, and in this patient group, semaglutide significantly improved symptoms, physical limitation, functional capacity, reduced inflammation. There was a significant benefit in terms of reduction in NT-proBNP. The hospitalizations were substantially fewer, but obviously this was not an outcomes trial, so very few events. And that semaglutide was well tolerated. In the interest of time, I did not show you a lot of the side effect results, but the only side effects which were more was the GI intolerance, but that is something that we know from the obesity trials as well. And we feel that on the basis of this, at least in the non-diabetes patient, we have now yet another effective therapy targeting obese HFpEF patients. Thank you so much for giving me the opportunity to present these results.
Thank you so much, Javed, for a very lucid and detailed analysis of STEP-HF trial. The benefits in this trial were truly quite remarkable, and it appears that we finally have a drug which consistently reduces obesity while imparting several other benefits in patients with heart failure. We'll have a discussion later on